as we're progressing down the spine, we've spoken about the head and the neck. We now talk about the various spinal pain, back pain, one of a better description. The erector spinae are probably the main culprits in this, according to Ingram. He says they play a large part in upper back pain and low back pain, along with quadratus lumborum. They're in addition, they influence the thoracolumbar corner. So if this is the thoracic and this is the lumbar, we're talking about this area here, basically an area of potential excess load between the thoracic spine and the ribs and the lumbar spine. So they're quite important. The muscles we'll discuss here will be the erector spinae, quadratus lumborum, gluteus maximus, and piriformis. So the erector spinae are basically made up of 3 groups of muscles, and they can be quite complicated, but you can simplify it quite easily with basically dividing them into 3 from medial to lateral. The spinalis group of erector spinae, the longissimus erector spinae, and the iliocostalis erector spinae. They have a multitude of sort of origin and attachments. All of the erector spinae cojoin with the thoracolumbar fascia down here, and it attaches at several different angles to the crest of the ilium and the sacrum, and the spinous processes of the lumbar and the 11th and 12th thoracic vertebrae. They will insert at different points posterior to the costal bones and the spinous and transverse processes of the thoracic and cervical vertebrae, and even up to the mastoid of the mastoid process of the temporal bone. So as you can see, we've got this thoracolumbar fascia with all this, and the ilium and the sacrum, and then the muscles are travelling up here, attaching into the ribs and the thoracic transverse processes and the spinous processes of the thoracic and cervical spine. His action is really to control forward flexion. If I just get the patient to bend forward, or the model to bend forward, they're actually by contracting and controlling it eccentrically. The semispinalis can also extend the vertebral column and the head. So if I just get you to bend back, and bend your neck back as well. So they will, the semispinalis will be involved in that, and relax. And you can get a unilateral contraction, which will cause an ipsilateral side flexion and rotation of the vertebral column and head. So basically, as they bend forward, and maybe even a little bit of rotation of the head. They play an important part in the spinal stability. As I said, they will sort of decrease the load as the body is leaning forward. They can repel pain from the lumbar area into the gluteal and sacral areas. They can also, a loose roll of pain is generally referred up and out with myofascial trigger points, and the erector spinae are quite good examples of this. Suboccipitals will cause head pain. Mid-thoracic myofascial trigger points can refer pain into the anterior chest, sometimes even mimicking heart problems. And pain experienced in the rib area can also come from erector spinae trigger points. So pretty much, I mean, when you're looking at the erector spinae, it's going to be something from here down around the medial border of the scapula, running all the way down to the lower back. It could be a big chunk of pain with a central referred area here. It could even be a specific area in the area of the thoracolumbar fascia, and again we can have that radiating up here, or just anteriorly with the pain sort of here in the stomach going up to the chest wall. So those are some of the areas you may experience with a erector spinae referred pain. Again, as I said, around the scapula, around the base of the scapula, they're all areas that when you see you've got these pains, you may want to consider it, needling the erector spinae. And when you do needle the erector spinae, be careful if you're further up in the thoracic spine. You can try and put a rib between you and the needle, or rather the needle and the viscera underneath. It's a much safer way of needling. So we're just going to have a look now at needling the erector spinae. So for needling the erector spinae, then obviously the patient is prone. Probably a shorter needle rather than a longer one will be more efficient and safe. One must be careful that we're needling within the laminar groove. So if we have the spinous processes, and as we drop off the spinous process, we'll feel the muscle here before we come out onto the sort of costotransverse sort of joints. And it basically, if one was to place a finger width between the spinous process and then you start to feel the ribs raising up, that's the laminar groove, and you're fairly safe if you're in there. And you want to try and needle within on the outer part of your finger, and keep like I said earlier, try and keep a rib or something like that between you and the lungs. And so in effect, what's happening is you've got the ribs here, you've got the erector spinae, you've located your trigger point. If you can find one and then the rib underneath it, it's better to needle over the rib. You keep your finger next to the spinous process, then you know that you're not going to go too near any other structures you don't want to, or going into the space, the intercostal space. I tend to try to needle in a kind of a diagonal sort of position, so then I'm not going posterior to anterior and running any risk. So I'll find the laminar groove, I'll find the muscle, I'll find the trigger point. If I can find a rib underneath it, that might be quite helpful. I will place the needle or the introducer onto the muscle or the trigger point, tap, and it will go in, and then my needling will be going in this kind of direction rather this kind of direction. And you can just as easily get into the muscle by doing that. Obviously you might search further down for the various trigger points along the erector spinae, coming all the way down to the lower lumbar to the lumbar spine, and even up down towards the sacrum. We'll have a look at that at a little bit closer angle, but these are the basic techniques for needling the erector spinae. For needling the erector spinae, it doesn't really matter if we're doing it further down the spine or further up the spine. Basically, we're going to use a 30mm needle. The patient will be lying prone. One needs to work with care so that you stay within the laminar groove. So these are the spinous processes, you just drop off of those, and the erector spinae will be in there. If I just get you to lift your back up, the whole of your back and your head as well, and you can see sort of the erector spinae working there. Now relax. So I'm going to stay within a sort of safe zone. I'll roll off the spinous processes onto the muscle, and as a safe needling zone. Preferably, I'm going to try and make sure that there's no rotation of the vertebral body or anything like that, and there's a rib between me and or between the needle and anything else. So if I find erector spinae and I find a rib there, I know I'm not going to go into the lungs. But if I go in a little bit too deep, I could if I'm not next to a rib. So I found a trigger point there in the erector spinae. I place the needle in. As I said, try to do. You can come from sort of medial to lateral or lateral to medial, but stay within the laminar groove and try and put a sort of rib between yourself and the viscera that's underlying it. So that's how you would needle erector spinae. Posterior anterior is possible, but again, because we're over the lungs, I try to keep it at a tangential angle, either superior to inferior, sometimes inferior to superior, sometimes lateral to medial, sometimes medial to lateral. But again, I try to make sure that there's something protecting the underlying viscera.